Hello, this presentation is about mother-infant bonding disorders. The term bonding disorders is widely used, but emotional rejection of the infant is more descriptive of the severe syndrome. The mother-offspring relationship is the foundation of mammalian survival, and it is hard to imagine a stronger or more enduring relationship. But it can be completely absent, as shown by criminal neonaticide. In the 18th and 19th centuries, the murder of the newborn was a public health problem. And post-mortem evidence showed that unwanted infants who survived could be starved to death. And there are more than 70 cases in the world literature. Now, this is the first case which was published with some clinical details. A child died at the age of 6 months. His mother was dominant, the father weak-willed. She completely lacked human sympathy and motherly feelings. The children were just a burden to her. She threatened to kill her eldest son, who was reared by his grandparents, because he tried to give his baby brother some milk. It was rumored that other children had died the same way. The corpse weighed 6.5 pounds, with no trace of fat. The gut was empty. And French and German writers were aware that a small minority of mothers hated their children, and that Oppenheim coined this term misopédie for hatred to children. And this is one of the cases that he described. A 36-year-old with tocophobia married on the condition that she would never become pregnant. She was bitterly angry when she conceived, and after the birth, she was cold and indifferent and unable to cuddle her or kiss her daughter, who seemed like a foreign being. The husband had to employ another woman to care for her. Bonding starts in pregnancy, and most mothers bond to the unborn child with fantasies about the baby, talking to the fetus, interacting with his movements, and sometimes involving husband and other children. And this can be assessed by several self-rating questionnaires. Prepartum bonding may fail to occur, and sometimes the interaction is negative. The infant's movements annoy the mother. In a small minority, this leads to fetal abuse and extreme manifestation of rejected pregnancy. In his pioneering paper, Condon described a 15-year-old who was refused a termination and regularly punched her abdomen in response to fetal movements. And some of his teenagers saw the fetus as devouring or destroying them, and 2 out of 5 abused their infants after the birth. Now, if the prepartum bonding is a problem, a therapeutic approach has been developed. This is the case described by Jernberg. A 24-year-old first-time mother became depressed in the third trimester. She didn't feel that she could bond to her child. And in treatment, she was encouraged to verbalize her anger against the child's father, who had deserted her. She was encouraged to look at her belly, touch and talk to the baby within, and sing to him. and she was asked to tell stories as of the birth and of the baby growing up. At first, she was a reluctant pupil, but she started to talk to her baby affectionately. She felt ready for the birth and became a proud mother. After the birth, most mothers soon develop strong and even overwhelming love for their infants. This is not automatic or instinctive, and there is no sensitive period. It is a process catalyzed by the infant's reciprocal response, such as infant smiling. Bowlby wrote, "Can we doubt that the more and better an infant smiles, the better is he loved and cared for? It is fortunate for their survival that babies are so designed by nature that they beguile and enslave mothers." Mutual gazing is another catalytic activity. A thorough observation of 30 mothers and infants found that mothers began to play with their babies at about 4 weeks, when they began to look at each other en face. Visual contact made them feel recognized in a personal, intimate way and could be used to calm or activate and figure out what was wrong. Gazing, the core of the dyadic relationship, became a mutually absorbing activity. And the same author conducted a pioneering interview study with 54 American mothers 3 months after the birth. And he found that many felt tired and distant from their babies for several weeks. And then at about 4 to 6 weeks, the baby became a person and recognized its mother. Feelings grew steadily until at 3 months, the mother felt a pang on leaving the infant. Now, 7 mothers had an accelerated maternal response, but in 9, it was delayed or absent, and they included 6 with an unwanted pregnancy. Mothers who are worried about a delay can be reassured that almost all achieve a normal relationship quite soon. Now I'm going to talk about emotional rejection of the infant, which is the main subject of this presentation. This has not received much recognition and almost no research, and what we know is based on clinical observation and indirect studies. And I shall suggest a few studies which I think would be useful. The syndrome of emotional rejection of the infant Yes, although emotions are graded, probably on several emotion dimensions, there are advantages in recognizing a syndrome of emotional rejection. For the clinician, it indicates the need for urgent intervention to prevent child maltreatment. And for the scientist, it initiates an investigation of a morbid clinical phenomenon into its causes, treatment, and prevention. Some perinatal psychiatrists consider that these mothers are suffering from postnatal depression with impaired infant interaction. This is not appropriate for a number of reasons. First, a relationship disorder is different from a mood disorder. Secondly, rejection can occur without a depression. Thirdly, only a minority of depressed mothers reject their infant, and it's important to select them for special attention and not to stigmatize the others. Fourthly, the risks to the infant are higher, especially emotional deprivation and child maltreatment. And the causes are somewhat different, with more emphasis on unwanted pregnancy and abnormal infant behavior. Dissociation of depression and bonding disorders is shown by a number of studies. In the Anglo-New Zealand study, 33 out of 84 depressed mothers rejected their infants, and also 13 who were not depressed. In a cohort of 570 Swiss women, pathological interaction and lack of pleasure were more common in depressed mothers, but were also found in a substantial minority of normal mothers. In the study of 85 women, by the very thorough contextual assessment of maternal experience, there was no correlation between postpartum depression and negative feelings about the child. Depression and bonding disorders have different treatments. An Iowa study concluded that psychotherapeutic treatment demonstrated to be effective in relieving the symptoms of depression had no significant impact on maternal responsiveness. Bonding disorders may respond to antidepressive treatment, but often require specific psychological treatment to which they respond well. It is therefore important that health planners, doctors, and the public are aware of the distinction between depression and bonding disorders, of the risks and the treatment response, so that these disorders can be referred for early expert treatment and facilities provided. Otherwise, many mothers will not receive effective therapies, and many children will suffer from maternal hostility, and this nascent specialism of mother-infant or perinatal psychiatry will make almost no contribution to the prevention of child abuse. There are three main groups of symptoms. Firstly, abnormal emotional response, estrangement, aversion, hostility, even hatred. Secondly, a wish to avoid or escape infant care, avoiding the infant, running away, transferring care, relinquishment. Thirdly, a wish for the disappearance of the baby by theft or death. Now, to illustrate some of these symptoms, this letter describes aversion in graphic terms. A mother blamed her son for her barbaric birth and developed a hatred for him and wished he would die from a cot death, something I knew I would not be blamed for, and nobody would know how I hated him. She repeated this phrase, I hated him. After 4 months, her feelings changed, and she wrote, I feel so deeply ashamed. I'm frightened he might know how I felt. I can't bear to visit friends and see them happy with tiny babies. Every time I see babies on the television, I cry because of the way I felt towards my baby. Such a terrible hate. Avoidance may take the extreme form of gaze avoidance. A successful woman, devoted to her 3-year-old daughter, conceived again. When the scan showed a boy, she began to feel negative about the pregnancy. After an easy labor, she felt empty and disappointed. I did not want to think about the baby. She became depressed and was unable to look at her son. It's his eyes. I can't look at him. I don't know why. I feel quite cold and empty towards him. She felt like running away or leaving him in a park. Although he was an easy baby, she shouted at him several times and shook the pram. With treatment, her relationship with the baby improved, helped especially by bathing with him. Absconding is another characteristic symptom. A multiparous mother became depressed after the birth of her third baby and was unable to cope. She took a train to London for no apparent reason. She was admitted to hospital without her baby for 3 weeks, and there she seemed perfectly well and was discharged without the relationship disorder being suspected. After returning home, she ran away twice and made a suicide attempt. She could not tolerate the presence of her baby. She was reluctantly persuaded to accept admission to a mother and baby unit and rapidly responded to treatment. Sudden and unexpected infant death is perhaps the worst disaster which can affect a mother. But in a series of 100 rejecting mothers, 22 wanted it. This is the first instance that we came across in the early 1990s. A mother looked forward to a beautiful baby tucked up in bed or going for walks, proudly pushing a pram. But he went only 1 hour between feeds and cried unless held. One night he screamed for 5 hours. After 10 days, she was exhausted. This was the biggest mistake of my life, she said. She considered adoption and moving away to start again. Later, she shared her feelings with her husband. We were surprised to learn that we both thought that a cot death would be a welcome release. This triad of symptoms is often associated with anger directed at the child, resulting in shouting, swearing, or screaming at the baby, and various manifestations of loss of control, which may reach the level of frank abuse, especially shaking. Now, in the Anglo-New Zealand study, among 206 referred mothers, 59 had some degree of pathological anger. Now, although this is strongly related to rejection, pathological anger should perhaps be regarded as a separate phenomenon with its own causes. Mothers whose self-control is impaired by sleep deprivation or depression, and whose circumstances, especially domestic violence, put them under intolerable strain, may misdirect their anger to much-loved infants. As for diagnosis, screening questionnaires are useful. There are 5 of them. Those of Muller and Condon have prepartum and postpartum forms. There's a Japanese scale, and there is the mother to infant bonding scale, which is based on visual analog scales. Now, the postpartum bonding disorder has the advantage that it's already been translated into 29 languages. It's very useful for screening and for following progress. And a factor analysis identified a factor with only 7 items strongly related to rejection and anger, though a total score is equally useful. The advantage of the PBQ is that it has been validated against interviews in Birmingham, Christchurch, and Hong Kong, against nurse ratings in Holland, against 10-minute play videos in Chicago, and against the Bangalore Maternal Behavior Scale in Chennai. An alternative approach, economical of time, is the enumeration of positive and negative comments. This has been employed for studying the mother-toddler relationship using the working model of the child. It can also be used in new mothers simply by asking them to speak about their children for 5 minutes. Self-rating questionnaires must be backed up by interviews to establish a solid diagnosis. The 3-page section of the Stafford interview deals with the mother-infant relationship. Some of its key questions are: have you been disappointed with your feelings for your baby? Did you ever wish that something would happen to her, him or her? Have you ever felt angry with your baby? What was the worst thing you had an impulse to do? And this 3-page section can be used as a self-rating, as a self-standing instrument. Observations of the mother-infant interaction are also most important. On inpatient or day patient units, nurses can record salient incidents, the competent skill of the mother, affectionate behavior, and her response to crises. There are nurse rating scales. For research, 5 to 15-minute videotapes of play or feeding can be used. There are some worries that rejecting mothers might find this exposure difficult, and that such a short period of observation may be possible for them to dissimulate, to conceal their difficulties. It is also important to determine how a rejecting mother's responses differ from those of depressed, anxious, and obsessional mothers. The most versatile method is by prolonged observation in the natural setting. This has not yet been done with rejecting mothers. This can use either a checklist of time sample and coded behaviors, the ethological method, or alternatively, as advised by a seasoned researcher, Ainsworth, a detailed narrative record of mother, infant, and infant behavior better preserves the flow of interaction. The power of these observations was shown by a study of only 10 infants, 5 home-reared and 5 living in an institution, which found an enormous difference in the frequency of showing affection. Estimates of the frequency of maternal rejection have been made in the clinic and in the general population. In the Anglo-New Zealand study, where over 200 mothers were very thoroughly interviewed with a 2-hour Birmingham interview, as well as clinical interviews, threatened rejection was found in 30, that is 14%. That threatened rejection means aversion and a wish for temporary placement. Established rejection, that is hatred or a wish to relinquish or a wish for cot death, was found in 22, 11%, and severe anger in 8%. Now, that is a frequency of combined threatened and established rejection of about 1/4 of mothers referred to specialist services. In the community, there have been studies using the postpartum bonding questionnaire. In Japan, 5 out of 364 mothers, that is 1.4%, had a total PBQ score indicating rejection. False positives will have somewhat reduced this percentage. In Sweden, 6 out of 727 mothers had scores on factor 2 indicating established or threatened rejection. So a frequency of approximately 1% in the general community sounds about right. Now we come to the management. And before any treatment is considered, it's essential to take certain precautions. Where there is rejection or hostility, the first decision is whether or not to treat, because of course, a baby does not have to be cared for by its birth mother, and to insist is dangerous. And this decision will be taken after detailed discussions with father and mother. If, as in most referred cases, it is decided to start treatment, the mother is not separated from the baby, but she is spared all irksome infant care. Someone else must look after the screaming baby. And if abuse is feared, she is never left alone with the infant. It is these referred mothers are usually depressed, and it is wise thoroughly to treat depression by psychotherapy or antidepressive medication, occasionally electroconvulsive therapy. The aim of specific psychological therapy is to create circumstances in which the mother and infant enjoy each other. And under the general heading of play therapy, various techniques have been used. Baby massage, participant modeling, singing lullabies, mother and infant bathing together. The power of playing is shown by this example. An intelligent, good-hearted mother failed to bond with her baby and tried to escape. She lived far from Birmingham, and we were wondering how we could get therapy to her when a health visitor came to the house and told her that she was not playing with her baby properly and demonstrated how to romp with the baby. As she walked on all fours with the baby on her back, the little boy cackled with laughter. The mother copied her, and at the next visit said something had happened. She felt a pang when her baby was taken to the childminder. She recovered within a week. As for participant modeling, this is the first mother that we encountered with this disorder in 1976. She had looked forward to her first baby, but developed what was called postnatal depression. And after several weeks in another hospital, she came to our service, and the first thing she said was, "I can't bear him. I don't want to know him." The child was fostered by her in-laws amidst severe family friction. I had to forbid contact. She failed to respond to inpatient and day patient care with several antidepressants, 3 courses of ECT, psychotherapy by 2 gifted therapists, and marital therapy. After 3 years, a clinical psychologist, Eileen Briley, visited the unit and said, "I know what this is." And she took over the treatment, and in 4 one-hour sessions of participant play therapy, established a normal bond, and her depression evaporated. Even severe bonding disturbances can be treated at home, provided there is sufficient family support to safeguard the infant and spare the mother all irksome child care. A day hospital can provide all specific therapies. Conjoint hospital admission is sometimes necessary in intractable cases or in the absence of home support. But hospitalization of the mother without the baby is useless. It merely postpones and aggravates the problem. As for the effects, most of these mothers are severely depressed. There can be few things more depressing than not being able to love your baby. But there is also stigma. At the Stafford International Symposium in 2018, a courageous doctor gave a moving account of her own experience of rejecting her infant. She said that in discussion with a close friend, she had hinted that there might be a problem. And the next day, her friend wrote to her husband, breaking off relations. In some cultures, it may be impossible for a mother to admit, even to herself, that she does not love her baby. The effects on the child include various types of maltreatment, of physical abuse, especially shaking by mothers with pathological anger, of neglect, emotional neglect in milder cases, at the extreme, starvation, and in chronic cases, emotional abuse, belittling and humiliation, critical or sarcastic comments, scapegoating, conveying to children that they are worthless and unloved, behavior amounting to paternal persecution. It also leads to cognitive delay. A thorough ethological study of 38 children aged about a year, including 7 home visits, showed that stimulating, responsive mothering was related to competence measured by the Bailey scales. The enormous Mannheim study, using interviews, home observations, and videotapes in 362 mothers at 3 months, 2 years, 4.5, and 8 years, showed that disturbed interaction was associated with cognitive delay. A control study in Cambridge of 61 mothers using brief audio and videotapes of interaction at 2 months showed that these interactions, not depression, predicted cognitive functioning at 5 years. And a study of 7,000 Australian mothers found that a negative attitude of the children at 6 months was an independent predictor of behavior problems at 5 years. We turn to the causes of this phenomenon. Emotional rejection appears to be a worldwide phenomenon affecting many ethnic groups. The Anglo-New Zealand study established that it affected Caucasian, Hindu, Sikh, Pakistani, Afro-Caribbean, and Maori mothers. There are reports of its occurrence in Egypt and Mexico, and there are studies from at least 7 different centers in Japan. The most prominent association is with depression. In a series of 100 referred cases, 98 were depressed to at least some degree. But the problem is the direction of the causation. The causal role of depression is favored by the occasional response to ECT, by the loss of a bond when depression comes on late in the puerperium, and occasional depressions with psychotic or bipolar features. The causal role of rejection is favored by recovery from resistant depression with play therapy. Unwanted pregnancy is another frequent association. Among 206 referred mothers in the Anglo-New Zealand study, several relative risks indicated unwanted pregnancy, such as that termination was considered, the presence of fetal abuse, lack of interaction with the fetus, and a negative attitude to pregnancy. Among the 100 cases, 36 had unwanted pregnancies, 14 had wanted a termination, 8 hoped for a miscarriage, 10 reacted to fetal movements with hostility. And this was found also in 2 Japanese follow-up studies. In a follow-up of 1,399 mothers, path analysis showed that unwanted pregnancy predicted bonding failure at 1 month with quite a high correlation coefficient. And in a follow-up of over 1,000 mothers, 6% with negative feelings about the pregnancy, compared with 2% of those who were delighted with it had a high PBQ score. One of the features of an unwanted pregnancy is a lack of prepartum bonding, and this has been shown to predict postpartum bonding, first of all by an exhaustive interview study of 19 first-time mothers, which showed a high association between attachment to the fetus and maternal feelings towards the baby. And there are at least 8 questionnaire studies showing that prepartum bonding predicts postpartum bonding with modest correlations. Another quite frequent association is a very difficult infant. Among those 100 cases, 32 had infants who were usually often screaming or occasionally unable to sleep. And this cause is supported by the literature on infant colic. For example, 16 out of 23 mothers felt aggressive, and 6 had thoughts of infanticide. Infant colic is a cause of infant screaming. Now, it might be thought that the mother's own experience of mothering in her own childhood was a predictor of difficulties with her own children. This is a popular theory, but in this study of 100 mothers, only 17 had a history of poor mothering, which might be no more than the general population. And furthermore, of 38 multiparous mothers, the disorder developed with the second or third child, not the first. Now, if it were built into the mother's personality not to relate to her children, you would expect it to affect the first child. This was also noted in Kurma's study. In summary, rejection of the infant, emotional rejection, is one of 3 of the most severe disorders seen in this area of psychiatry: suicidal depression, psychosis, emotional rejection. And it is the most frequent. Suicide is 1 to 5 per 100,000, psychosis 1 in 1,000, emotional rejection 1 in 100. And it is the disorder with the greatest effect on the infant. As for maternal depression, that's difficult for the infant because of the mother's demoralization. But many of these depressed mothers make great attempts to achieve normal mothering. And if there is maternal suicide, then the effect on the infant depends on those that take over its care. With psychosis, an infant has to put up with a mother being ill for a few weeks, about once every 6 years. But with emotional rejection, if it becomes chronic, there is this maternal persecution. At the moment, the maternal rejection of the infant, is a clinical syndrome. But the mother-infant relationship resides in a complex sequence of cerebral events involving sensory analysis by the frontal lobes, emotional activation in the limbic system, and action in the motor areas. In the last 20 years, extensive studies of normal mothers reacting to pictures of their infants crying or smiling have been conducted using fNMR and other methods of studying cerebral blood flow, the so-called parental brain. And neuroscientists have begun to study depressed mothers, but there's only one study, that by Musa in 2012, which included maternal sensitivity. That was studied by 8-minute play therapy, play videos. And there were some differences between sensitive and insensitive mothers. But rejecting mothers can be studied when in the throes of the disorder, and because so many recover spontaneously or with treatment after recovery. And a comparison of these two would give us an insight into what is happening in the brain. Even a single study could be useful. And if consistent changes were found, this syndrome could be redefined as a cerebral disorder. Thank you very much. If anyone would like a copy of this presentation, they can request it by email.